Welcome to the 5th World Congress of Medical Sexology. This Congress is sponsored by
Hi, my name is Dr. Bianco. I'm an associate professor in the Department of OBGYN under the Division of Maternal Fetal Medicine, and I work in the Center for Fetal and Maternal Health at Stanford University School of Medicine. Today, I have the pleasure to talk to you about abnormal presentations in our clinic and in our clinical practice when there is abnormal chromosomes manifestations in the pregnancy and then in the fetus, when we have to figure out how to address abnormalities in the sex chromosome, how to approach it with our family affected, and what to do and to have the best approach for this infant that is affected. So what we're going to be talking today is talk about this abnormal development of the sex. There is investigations based on genetics, hormonal laboratories. We are going to talk in the classical genetic syndromes of abnormal sex chromosomal, like Turner, Klinefelter, triple X and XXY. And we're going to talk about it, how to approach it, and what specialists could help with further develop this infant and to a normal sort of adulthood. So in general, these are conditions that we know they're congenital. This could impair the development of sexual development, gonadal development, and also the phenotypic implications and how this infant is going to look. So we will have abnormalities in the phenotype expressing ambiguous genitalia. It can be due to androgen insensitivity, abnormal gonads, or like not having a determined sex genetically, or wanting it to change the sex regardless the genetic determination. Here in this nice diagram, we sort of put together the different components that is going to determine what this individual is going to be defined sexual, if you will. We have the sex that's determined hormonally, and that's going to tell you how your organs inside and outside are going to be developed. We have the sex determined by the chromosomes. XY is a male, XX is a female. We're going to see how that sex chromosome gets to be a genetic sex, meaning the presence and the absence of SRI. That is actually what is going to determine the expression of the genitalia. And also we have the gonad itself. What are the gonads that are present in this individual? So looking more into the genetic pathways, we know if we started with a male determined by the XY chromosomes, the region, the sex-determinant region, SRI, it will be expressed and will use the pathway of SOX9 and SF1 and other genes that are being investigated currently to develop further testes. But in the contrary, if we have females, XX chromosome, but that pathway doesn't get quite developed because we're going to go to the pathway WNTA4 that actually use DAX1 as a primarily gene to help to the permanent ovaries and at the same time to inhibit sort of the pathway SOX9. There are other genes being identified like TAF2 to also be part of this pathway to further stimulate ovaries in the gonads, not testes. So there is the phenotype that is going to be defined by the sex, how these genitalia, external genitalia, internal genitalia are going to be developed. And there is the ability to assign the sex for this individual, if you will, like the social assignment. Is this a girl? Is this a boy? Is this going to be developed as a female? Is it going to be developed as a male? What that becomes more as a social assignment, not so much as a physiologic genetic determination. But let's look more into this. So what happens when we have somebody with development on this morphology or abnormality of sex development. So the infant gets born, and we really have sort of like an emergency. First of all, because it's not expected, and we don't know if this is due to abnormalities, anatomically abnormalities. Is it due because genetic determinations? What is causing this? So we definitely have to treat this as an emergency. We need to have a multidisciplinary approach to this infant, and we have to address things that can be life-saving, meaning we have to make sure there is no salt wasting disease, there's no abnormalities in the electrolytes, and there's no issues in 70OX progesterone pathway, such as congenital adrenal hypoplasia, because that could lead to the infant to die in hours. We also have to think about it. Well, what else we're going to do other than looking at basic metabolic panels and look at imagings, look at the pelvic imaging, see where are the organs. Can we see any testes, any ovaries? What are we seeing in this bigger infant that we can't quite understand yet? What is the sex determination? We also have to do vasals and stimulation endocrine testing to see how abnormal is the state of this infant. But we also have to send laboratories to investigate, interrogate the genetic determination, meaning now as a primary tier is a chromosome microarray, no longer the classical karyotype 46 metaphase. No, now we're doing a little more than that. We're going for microarray and even for a whole exome sequencing. Moving from just a whole integrated microarray might be more in this type of presentation, lead to more result if we actually deep down in the sequencing of the genome and trying to figure out if this is a deletion, a mutation, a base pair change, and we can go all the way up to whole genome sequencing. It's just lengthy. It could take up to 6 months to get a result, and also it's super expensive. So it's always good to start with just a basic chromosome microarray. So what do we have traditionally available to us? With traditional, we had for chromosome abnormalities, for the sex chromosome, we could do just traditional karyotype, metaphase. We can look at FISH. That will be a rapid read. Within 48 hours read, we can know if there is a missing X or duplicated X or Y. And now, recently, that is actually revolving and causing a big revolution in the prenatal field. We have what we call the non-invasive prenatal testing, meaning that by 10 weeks, these patients can take a blood testing without affecting the pregnancy, not an invasive procedure, it's just a maternal blood sample where we can actually interrogate the fetal genome utilizing cell-free DNA circulating in the maternal circulation, and less than 200 base pair can be interrogated, and we can see if there is any duplication or any missing information, and even do a whole sequence at this point. It could help us to determine if there is a missing X or duplicated X, or there's any evidence of trisomy 21 that will lead to Down syndrome, trisomy 18 or 13. So common things that we deal every day in our prenatal field. Now it's readily available as early as 10 weeks. So this is definitely changing the way that we're approaching these sex chromosome abnormalities, because we are picking them up more often and they're quite prevalent. So let's just dig into the most common syndrome in females called Turner syndrome. So we know overall this is presented in girls, and there's an absence of one of the chromosome X. So it's an X0 for the most part. It's sort of like a mosaic presentation. And missing that X, it really changes the phenotype in our girls. It can have congenital lymphedema, cystic hygromas. They can be short. They will have gonadal degenesis. It's quite prevalent, about 1 in 2,500 to 3,000 live births. Is actually the most common chromosome abnormality leading to spontaneous miscarriage. We know that overall, just about 1% of the syndrome will get to full term. In general, it's when we do the analysis, the chromosome will be X0. Although, we can see duplications like isochronomy that can lead to this syndrome, and we also can see different anomalies in the X chromosome that will lead to the syndrome as well. So we can diagnose it as early as the first trimester, like you can see here in this ultrasound. This fetus less than 12 weeks, we can see a cystic hygroma, very, very infiltrated, full of fluid around the fetus, and this baby definitely has cystic hygroma, and it might have a congenital heart defect, but it's pretty sick, and it most likely will just lead to a miscarriage. We can determine through analytes having abnormalities in ACEs and estradiol. And we can determine just by invasive procedures doing CVS, a chorionic villi sampling, or an amniocentesis by 16, 17 weeks. But now with the non-invasive testing, we can have a highly yield screening, knowing that we are missing one of the X chromosome. So this is just to show you a little bit the phenotype. They're short, they have broad chest, short webbed necks, distribution, the pubic hair is different. They could, they're short, but they can actually, a lot of these affected women can have a full length of life. Here we have the example of this woman that is affected by this syndrome, and she's married and she's a doctor. There's growth hormone treatment, there's surgical repair, patients get a special aid right away. Weight could be a problem, obesity could be a problem, but they can learn how to deal with that. They can engage in physical activity, they can walk, they can swim, bike through all of their life, have healthy habits, and they can actually now, through assisted technologies and fertility, they actually can carry pregnancy, not with their own eggs, most likely through an egg donation or embryo donation, but they could be able to carry on pregnancy as long as the cardiovascular risk has been assessed and they don't need surgery and they're stable for pregnancy. What do we know about their presentation from the point of view of social behavior? We know about 10% of these cases who have problem growing. They will need definitely special education and like assistance through all their life. But a lot of them will do well. They would be identified with learning difficulty that they can overcome. More is more perception with motrice perception, not so much verbal. They in general identify themselves as females. They tend to be heterosexual. They are interested in sex, and they actually successfully have sexual intercourse as they develop as a woman. From the point of view of mental illness, mental illness has been documented between 2 to 10%, which is actually lower than general population, less that it tends to be about 14%. There's a study very interesting published in the Journal of Clinical Endocrine Metabolics that looked at 80 women with Turner, and they looked at the experience with intercourse, with a mean intercourse of about 23 years. Half of them, like about 55%, they also address this population in France, looking when the first intercourse happened, and by 20 years, a lot of them had intercourse. Some of the limitations were if they had cardiovascular involvement that could be associated with severe adolescent morbidity. Also, regardless if puberty or the type of puberty happened spontaneous or induced with hormone replacement, did not affect the age of the first kiss or date. They identify as a woman, and they feel that they could perform normally. They do, however, have low level of androgens. Therefore, that could be an explanation for low for female libido to be under the normal levels. So how do we know? What do we know? How long these women tend to live? Well, in a series that look over 500 patients, Some of them, about a third, like 30 of them, were lost by heart defects. There was a range between 27 years old, but it could go all the way up to 80 years. So the range was very broad. And we knew development, hormone replacement, cardiac surgery, assisted reproductive technologies. These women had experienced the full life experience. So there is encouragement in improving the quality of life in this genetic syndrome. So now let's change a little bit and think about sex chromosome abnormalities in the male. The most common is this Klinefelter syndrome. It was described as early as 1942 by Dr. Harry Klinefelter. And these males have a phenotypically characteristic very recognized and described, such as dysgenesis of the organs. The testicles are small and then not to descend normally. They have higher level hormones in the urinalysis. The testicle itself are hard and underdeveloped. The penis is small and not fully developed. There is azoospermia and also presence of gynecomastia. This is another syndrome that has benefited tremendously of the advance of the assisted reproduction technology. Even with testicle biopsy, some of these males are being able to conceive and have kids. So there is more and more advances understanding this syndrome and helping with hormone replacement. So what else we know? We know that they're the most common in male. It's about 1 in 500 live birth in males. It goes up as the chromosomes gets more abnormal, sort of like 48XXYY. And then we could go all the way to 4X and a Y, and we see like 1 in 85,000 to 100,000. We can also see, interestingly, chromosomes analysis karyotype being reported as 46XX. So as a female, genetically reported, but it's really Klinefelter's, because that region of SRI, that it is introduced through meiosis and from the contribution of the paternal chromosome gets expressed, and it gets the phenotypic expression of the syndrome of Klinefelter. Here you can see a nice figure where you can appreciate these are individuals are tall, thin, narrow chest, broad hips, pubic bone distribution as a female. They have a small fallow. They have very poor bear growth. They have frontal baldness. They tend to have less hair in the chest. The narrow shoulders. So the testicles are small. They have very thin and long legs. So it's pretty characteristic. We know that when we look about the development through the sexual behavior, we know that the genitalia is not well developed and the fallow doesn't reach normal length, and the testicles are underdeveloped as well. This study that looked at sex chromosome abnormalities reported that by the end of puberty, the penis could be reaching a normal size in about 77% of the participation, and the time registration for the pubic hair could be about 10 or 5. There's definitely decreased energy and libido because it's decreased related to the decrease of testosterone. So definitely hormone replacement plays a definitely important aspect here, because will improve self-esteem and well-being. These kids can have problem with speech, so speech therapy is definitely encouraged. Physical therapy as well, just because they can have delayed gross motor skills, low muscle tone, balance, coordination. Some of them can have dyspraxia, so occupational therapy can be recommended and utilized intensively. Um, they overall can receive a comprehensive psychoeducational evaluation and see what are the strengths and weakness. And this can be helpful for planning and classroom placement and resources. Consultation with development behavior pediatricians is always encouraged. Here we can see phenotypic look like person with Klinefelter. When they look at their identification, sexual identification, the majority identified as heterosexual. They feel friendly and they feel that they have enough friends. A lot of them were already related to females and dating. Some of them have diagnoses of mental illness, such as depression, and also drugs abuse. They can be a little violent and face misdemeanors. We regarded life expectancy, they actually do very well, although they face comorbidities such as diabetes and cardiovascular issues. They can have problems with the GI tract and respiratory as well. There is a very comprehensive study that is published from Edinburgh, where they looked over almost 35,000 live births between 1967 and 1979, and they looked at these babies that had sex chromosome abnormalities, and they were able to follow some of them up to 1995, and they found that different characteristics, and they were compared with normal population and to the siblings. They found kids that would die from renal genesis. Some of the boys might have a problem engaging socially. Some of these other boys that would carry a different chromosome, sort of like XYY, it's also known as a Superman, or can have a little different presentation, similar to Klinefelter, but a little different presentation. The IQ can be diminished. They can have problems with language. They can be a little immature emotionally. They definitely very tall, and they could have misbehaviors. They also looked at the chromosomes with triple X, Superwoman. They had about 16 girls. They understand and studied from age 16 to 27. There were a few girls affected with kidney issues, with PDA and congenital hip dislocation. They definitely have problem with language, and the IQ tends to be diminished when compared with control and siblings. How they adapt to normal life is all about having a multidisciplinary approach, early recognition, and early intervention. We also have a Bender et al. Report from Colorado that was published in Genetics in Medicine that looked over 40,000 newborns between 1964 to 1974, identified about 35 males and females with sex chromosome abnormality, and they used their siblings that were normal, euploid chromosomically, and they did formal and informal interviews to get this data. They had an incidence about 1 in 400 live births with chromosome abnormality, sex chromosome abnormality. That was quite remarkable. And we've seen it these days now that we're doing more and more non-invasive prenatal testing in the field of pregnancy and genetic testing, and it's becoming more prevalent for us to speak about this. So the most common no-mosaic karyotypes that were reported in this study where it's Klinefelter, Toner, Triple X, and XYY. They had some psychosocial issues as compared with the siblings. They had less educational achievement and success, but they were all, for the most part, able to finish high school, marry. They had a living, they were independent, and they were able to hold a job. This is just to show you, coming from this group, very interesting, from a children's hospital in Colorado, how they approach these sex chromosome abnormalities as an interdisciplinary evaluation treatment for these kids and adolescents. So you can see we start from like developmental behavior pediatrics, child psychologists, pediatric neuropsychologists, speech language, occupational therapy, pediatric endocrinology, nurturing, social work. It's a very comprehensive approach because we need to, from the time it's identified, we need to have a early intervention, work with genetic counseling, assess the need for hormone replacement, need for medical and social behavior modification, being followed by endocrinologists. So it does take a village to help these kids to achieve fully development. And it's also an approach for research, education, and advocacy. So in conclusion, when a baby is born with development of the sex, with disorders in the sex development, is definitely an acute occasion. It's definitely an emergency. Not only because the infant could be quite ill, but also it's unexpected, and we need to approach it from many ways. And also we need to provide as much information we can to the parents that were not expecting this, and now they need to understand the different presentations and different challenges that this infant might have due to a abnormality in the sex chromosome. So we have to have all hands on deck and have a multidisciplinary approach when this infant is born and identified. There's definitely an increasing need or training more genetic counselors, more geneticists, more sexologists, medical sexologists, therapists, so we can have a multidisciplinary approach to these kids affected by sex chromosome abnormalities. Well, it's been a pleasure. I hope you have enjoyed the talk. Thank you for listening.
Welcome to the 5th World Congress of Medical Sexology. This Congress is sponsored by